I take Dr. Mudit Agarwal, who is onco-surgeon at Rajiv Gandhi Super Speciality Hospital, Delhi, and he's also the convener of Delhi Head Neck Oncology Group. So, Dr. Mudit, please, I welcome you and to deliver a few words to our participants and to our audience. Nidhi, has Dr. Mudit joined?
He did join, but I think there is some. He is unable to speak. Maybe we can start.
Can you invite? Can you upgrade him to the panelist? Maybe.
Yeah, I have done it, but it's not getting upgraded. I think we can start. He is sending me a message that we can start. He's having some network.
Otherwise, in the meantime, you work on it.
He's having some network issue. Even if I upgrade him to the panelist, then yeah.
Okay. And Dr. Mudit, please, you're most welcome to the this session, and please feel free to make any comments if you feel is necessary, and please provide your inputs to us. So, without any delay, let's start our first session, which is a talk on the management of mandible in oral cancer. The speaker is Dr. Rohan, and this will be followed by a discussion of 15 minutes. And the faculty for the discussion is Dr. Harshthar, who is onco-surgeon at Medica Super Speciality Hospital, Calcutta, and Colonel Vikas Gupta, who is onco-surgeon at RNR Army Hospital, Delhi. So, Dr. Rohan, you can start, please.
Ma'am, the host has disabled screen sharing, ma'am.
No, ma'am, I haven't.
Okay, I will check once again.
Yeah, please. Wait, I'll make you a co-host. Huh?
Yeah. Is my screen visible, ma'am?
Yes, it is. Very clear.
Okay. So, good evening, everyone. I'm Dr. Rohan Gupta. I am MCHSR at AIIMS New Delhi. I will be talking today on the management of mandible in oral cavity squamous cell carcinoma. So, starting with the functions of the mandible. So, mandible is very important for the airway stability. It has attachments to genioglossus and mylohyoid muscles, which helps in tongue protrusion and airway patency. Next, it gives dentition, which helps in mastication as well as deglutition. The central arch anchors the suprahyoid muscles, which helps in laryngeal elevation. It helps for articulation as well. It gives support to the mid part of the lip and the face, which helps for oral competence. And also, it is very important for facial aesthetics and symmetry. So now, when we resect the mandible or when we do any kind of surgery on the mandible, not what common issues do we face? The one of the issues if we dissect the central muscular attachments of the mandible is tongue fall, which results in airway compromise. Second, the patient who undergoes such a surgery usually is having difficulty in his routine mastication, which he used to have preoperatively. The patient's speech and articulation is affected, as well as the occlusion is affected. As the mandible supports the lip, the oral competence as well as swallowing is also affected, and a facial aesthetics of the patient is quite affected. And this is a image of Andy Gum. He was a popular animation character, which shows a completely deformed lower jaw. The patients who are having extensive resection of the lower mandible are usually referred to as Andy Gum deformity. So now I will be just dealing with the blood supply in the anatomical considerations. So the blood supply of the mandible is can be arterial, which is by the inferior alveolar artery, and can be periosteal. So the periosteal blood supply comes from the branches of the lingual as well as the facial arteries, and the muscular attachments to the mandible also gives the periosteal blood supply, and the venous drainage is through the pterygoid venous plexus. So now there is a very commonly quoted paper by Dr. James S. Brown, who has given the pattern of tumor invasion and the spread of the tumor in the mandible. So there are two patterns of tumor invasion into mandible by oral cavity squamous cell carcinoma. It can be either infiltrative or it can be either erosive. So the erosive pattern, which is considered as the lesser aggressive one, here the tumor advances on a broader front, and there is a connective tissue present between the tumor and the bone, and it is an osteoclastic dependent activity. So a broad front tumor with the connective tissue in between the tumor and the bone and an osteoclastic dependent activity. But when we come to infiltrative pattern, in infiltrative pattern, the tumor doesn't advances on a broad front, but it advances on finger-like projections, and there are islands of it, and it advances into the cancellous spaces, and there is no intervening connective tissue layer in it, and there is little osteoclastic activity. Infiltrative pattern is considered to be the more aggressive one as compared to the erosive pattern. So Wong et al. Looked at the survival in relation to the pattern of invasion of the mandible. So the 3-year disease-free survival uh, in the infiltrative pattern was only 30%, while in erosive pattern it was 73%. So as the size of the primary and the depth of the invasion of the tumor increases, the chance of infiltrative pattern of bone involvement increases. And infiltrative pattern is associated with extracapsular spread as well as N plus diseases. Now, there are various routes through which a tumor can enter into the mandible. It can enter from the oral cavity through the occlusal surface, through the mental foramen, through the mandibular foramen. Secondary tumors of the neck can erode the lower border of the mandible. There can be cortical defects in the edentulous stage of the mandible. It can enter through the periodontal ligament in the dentate mandible, or it can also enter through the attached gingiva. So, as given in this paper by Dr. James S. Brown, so he studied approximately 100 mandible, and he found that the tumor enters the mandible at the point of abutment, which is at the junction of the attached and the reflected mucosa, which is the point where the floor of the mouth abuts the mandible. So the tumor preferably enters the mandible directly. Directly means at the point of abutment, rather through the crest of the ridge or the periodontal membrane. So now the periodontal membrane is a membrane where the teeth attaches to the dental socket. So there is the periodontal membrane present between it. So as I mentioned in the last slide, the point of abutment is the direct entry point, which is the junction of the attached and the reflected mucosa over the mandible. So the tumor enters the mandible at the point of abutment. So as we can see in here, uh, as when the patient becomes edentulous, the attached mucosa, which almost disappears, and in the mandible, and the unattached mucosa slowly, as the bone resorption occurs, it increases. Now, coming to the assessment of the bone erosion in the radiological aspect. So when we get a 3D imaging, we can get either an axial view or a coronal view. So axial view is to get the horizontal extent of the bone erosion, but coronal view is taken to get the height of the uninvolved segment of the bone and to judge the paramandibular disease height, the height of the free bone from the paramandibular disease, and also to look for the breach of the mylohyoid line in cases of floor of mouth lesions. Now, OPG is a very low sensitive investigation. It needs usually 30% of bone demineralization to be sensitive for bone erosion. But it is a very good investigation to judge dental anatomy and some dental pathologies. Now, the most commonly used investigation in our clinical settings is a computerized tomography or a MRI. So there are various meta-analysis, there are various trials, which some say that CT is good, some say that MRI is good, but in general, These are the figures which I have taken from the three meta-analysis by Netto et al., Kao et al., and Chua et al. In all the three meta-analysis, the figures are quite comparative as compared to CT and MRI in the sensitive and specificity, but still CT is more specific, as we can see here in numbers, and MRI is more sensitive comparatively for bone erosion. Now, coming to the types of mandibular resection. So, majorly there are two types of mandibular resection. It can be either a marginal mandibulectomy or a segmental mandibulectomy. So, marginal mandibulectomy is usually done to achieve adequate margins and cases which are having no bone erosion or with superficial bone erosion. It should be avoided in a patient who has received radiotherapy, and it should be avoided in edentulous mandible. But in few cases of edentulous mandible, it can also be done when the surgeon is confident that he can have a remnant height of the mandible minimum 1 centimeter. And it should be avoided in patients which are having gross paramandibular disease, so that we don't have a third dimension margin as a closed one. Now, coming to types of marginal mandibulectomy, there is horizontal marginal mandibulectomy, oblique marginal mandibulectomy, vertical marginal mandibulectomy, or reverse marginal mandibulectomy. So coming first to the horizontal marginal mandibulectomy, it can be done for buccal mucosa or floor of mouth lesions. You should preserve at least, the surgeon should try his best to preserve at least 1 centimeter height of the remnant mandible so as to avoid the stress fracture, as the rim left is usually quite small. Now, while doing such a resection, we should always try to make curved cuts rather than right angle cuts, as right angle cuts more predisposes towards stress fracture, and we should try to make a boat like bony defect. Now, vertical marginal mandibulectomy. Vertical mandibulectomy is usually done for floor of mouth lesions or tongue lesions. As lingual plate is weaker than the buccal plate, so with an isolated buccal plate excision, the remnant bone may not withstand the subsequent weight bearing, and it may undergo fracture. Hence, isolated buccal plate excision is risky, and hence it is vertical marginal mandibulectomy is usually practiced for floor of mouth lesions. Now, coming to reverse marginal mandibulectomy. Reverse marginal mandibulectomy is usually done when the lesions uh, are fixed to the lower border of the mandible, or they are invading the mandibular periosteum. So in these cases, a reverse marginal mandibulectomy can be done. There are risks of exposing the dental roots, but when there is no gross bony erosion and the surgeon has the chance to save the mandible, then always a reverse marginal mandibulectomy is a good option, as the patient doesn't have a intraoral defect, the patient's dentition remains intact, and we can get the disease clearance also. Now, coming to segmental mandibulectomy, usually done in cases with gross bony erosion in post-radiotherapy settings, in patients with are having gross paramandibular disease, and the cases in which are edentulous and there is no enough remnant height of the mandible. Now, the types of segmental can be posterior segmental mandibulectomy, or lateral segmental mandibulectomy, or hemimandibulectomy, or central arch resection, or a extended hemimandibulectomy. Now, there are different classification of mandibular defects given by, but I have included only three here for today's discussion. First is by Boyd's, which is also called as HCL classification. Next is Urkums, and third is the Browns. Browns is one of the most commonly accepted and practiced. Now, coming to Boyd's classification, initially this classification was given by Boyd's and Jewer. When initially this classification was included, only three classes were included, which were HCL. Later, it was modified by Boyce, and it also included some suffixes so as to include soft tissue defects into it. So the term H refers to hemimandibulectomy, and it stands for lateral segment defect of any length which includes condyle. C refers to central arch defects, which includes the entire anterior segment, including the two canines and the four incisors. L stands for the lateral defects, which includes which excludes condyles. So H and L defects may reach midline and even extend slightly beyond it, but unless the entire anterior segment is involved, it is not classified as or LC. So HCL, these terms are can be used together according to the type of the defect produced. As we can see in the image, for the central, as in the first image, H is referred for hemimandible. Any extent not crossing midline and the condyle is included, then it is hemimandible. And if the condyle is excluded and the mandible is not including the contralateral canine and incisor, then it is labeled as L. And C is for the central arch. And these letters are used in combination according to the type of the defect which is produced. Now, coming to the next, now Boyd modified this HCL classification in 1993, and he added the word OMS as subscripts to the three uppercase letter, that is HCL. So O means no mucosal or skin component, M means a mucosal component, S means a skin component. If we add the word M and S, it means mucosal as well as a skin component. Now coming to a Erkan's classification. Now Erkan's classification is also known as CRBS classification. By C we mean condyle, R we mean ramus, B is body, and H is S is symphysis. Now if we remove only half symphysis, then it is SH. If it is total symphysis, that is from canine to canine, then it is S. Now it was a quite complicated classification, hence it was not popularized much. Now why it was complicated? He added many superscripts to the bony defects, which were already CRBS. So M to be added to any bony defects to indicate a marginal resection in that specific part of the mandible, and the soft tissue defects can be described with the subscripts like L means labial, B means buccal mucosa, SP means soft palate mucosa, FY means floor of mouth mucosa, T means tongue, and C means cutaneous. The above is again subdivided with various superscripts based on the location of the defect, for example, anterior, posterior, or lateral. And if a nerve is also resected, then a neurological defect N is followed by a subscript. IA is inferior alveolar, L is lingual, H is hypoglossal, or F is facial. So it was a quite complicated classification to include all of this in a single for a single patient, and it was not popularized and not practiced in every center. So next, Brown et al. Gave a classification in 2016. It was based on the principle that the mandible has four corners: two vertical corners which are at the angles, and two horizontal corners which are centered at the canine, and these are essential to maintain the function and aesthetics of the mandible. These are the points of change in the form of the mandible. While doing reconstruction with a bone graft, increasing need of shape of a graft is done at these points of, means these are the points of osteotomes. And increase in morbidity happens in terms of aesthetics and functions as we go from class 1 to class 4 in the Brown's classification. So class 1 is no condyle or no canine and in an ipsilateral defect. That is, the defect doesn't include the condyle and it remains lateral to the canine, and the defect is ipsilateral. When we add the suffix C to it, it becomes that the lateral segment along with the condyle is resected. Means we are remaining lateral to the canine and remain with resecting of the condyle. Coming to class 2. So class 2 is when our defect is going beyond the canine, and when we also include condyle, it becomes class 2C. Now coming to class 3. Class 3 means it includes both canine, but neither of the angle of the mandible. Coming to class 4. Class 4 is extensive defects. And in this extensive mandibulectomy, it includes at least one angle and both the canines. So when class 4 is also done with resection of a condyle, then it is also known as class 4C. Then it is called as class 4C. Now, coming to the last part, that is the mandibular preservation. So, in neoadjuvant chemotherapy is usually practiced commonly for borderline resectable diseases in head and neck. But they are also being given in head and neck for mandibular preservation. So there is a popular article by Lesitra et al. It had two arms. First is the standard arm, and second is the surgical arm. The standard arm was followed. The standard arm was surgery followed by port. It included 98 patients, and the experimental arm was NACT followed by surgery and port. It included 97 patients. So they give 3 cycles of NACT of cisplatin 100 mg per meter square and 5 FE of 1000 mg per meter square. So in terms of survival, there was no difference in the overall survival in the patient, but the mandibular resection was could be avoided in approximately 21% of patients. Similarly, there is a prospective phase 2 randomized control trial by Chalker et al. From the Tata Memorial Hospital to compare mandibular preservation in upfront surgery with neoadjuvant chemotherapy followed by surgery in operable oral cavity cancers. So the aim was to get the potential role and safety of NACT in tumor shrinkage and horizontal mandibular preservation. 68 patients were assigned into the surgical arm and the intervention arm. The intervention arm received 2 cycles of NACT, which was followed by surgery. The primary endpoint was mandibular preservation rate, and the secondary endpoint was disease-free survival and the treatment toxicity. Now, mandibular preservation rate in this trial was 47%. Out of 34, 16 patients had their mandibular preserved, and disease-free survival and overall survival was not affected by it, and it was overall similar in both the arms. All the patients in the intervention arm received adjuvant chemoradiotherapy, means the patient who received NACT received adjuvant chemotherapy as well as radiotherapy after surgery, but the patients in the surgical arm were treated as per the final histopathology report. Now the phase 3 of this trial is undergoing and it is awaited. So that is it from my side. Thank you.
Dr. Harsh and Dr. Vikas, would you like to ask some questions and start the discussion, please?
Yeah, I think it was a very good presentation by Dr. Rohan. Any questions from your side, Vikas sir, or you want me to ask first?
You can go ahead, Dr. Harsh. Vikas.
Okay. Okay. I think already the indications have been quite well enumerated. Indications for marginal mandibulectomy. Any specific things, Dr. Rohan, during surgery that you will watch out for, or any particular complication during marginal mandibulectomy that you would like to prevent, and what precautions would you take?
Sir, while doing a marginal mandibulectomy, I would one of the most common point of fractures is at the ankle of the mandible. So
Absolutely.
I will try to keep maximum remnant height of the mandible there, and will not try to take sharp angles. Will try to take curved angles only during my osteotomy.
Correct. And the angle should always be supported by your assistant when you are, exerting the force, or even if you're using a saw or whatever you're using, the angle of mandible should always be supported, and you should, as you said, a height of 1 centimeter. Mandible should always be given. Where exactly did we, or how exactly did we land up with this 1 centimeter? Any idea? Are there any studies?
Sorry, sir, I'm not.
Okay, it will be interesting for you to read it up also. These are in vitro studies, okay, not in vivo, but in vitro studies with artificially generated mandibular complexes. And I think one paper was from Japan quite a few years back, where they looked at where they exerted the mandibles to various traction forces after doing a marginal and keeping various heights. So they finally came down to the height of 1 centimeter being the minimum required. So most of these are experimental and engineering driven studies. It'll be interesting to read up.
Studies also. There is one
Yeah,
cadaveric study also. Where
one
they have
cadaveric
seen
study. Right, right. Okay.
Okay.
When you're doing as you had said, would you want to briefly enumerate for us the choice of flap based upon the latest James Brown classification of mandibular defect? Like the James Brown classification that has come, the latest one which you presented last. The advantage of that classification is that in comparison to previous classifications, each classification defect that is there, they have already advised what kind of reconstruction that can be done. So would you want to just enumerate how you would go about your reconstruction planning?
Um,
You can see the slides and tell. If you don't remember exactly, you can just open your the classification and then you can tell.
uh, sir, for class 1,
Yeah.
we can
See, think simply. What do you do in your normal practice? What is advised in your normal clinic? Like,
in
when would
normal
you be
clinic,
doing a bony flap? When would you be doing a soft tissue flap?
sir, in
When
class
is
1,
the
yes, sir.
Yeah? Go ahead. Go ahead.
Sir, in class 1 tumors, bony as well as soft tissue reconstruction can be done, sir. Uh, as it is a lateral defect, we are not going towards the midline. Both the reconstruction can be done, sir.
Uh, would you just want to elaborate? Like, suppose it's a class 1 defect here where the condyle has been preserved, ascending ramus and part of the condyle would be reserved. I mean, it's preserved. What would be your ideal choice of flap in this kind of a case?
Sir, we should reconstruct with a bony flap as
Correct.
the con. Yes, sir.
Yeah, absolutely. You should reconstruct with a bony flap wherever you have bone to anchor behind, I mean, proximal and in a distal position. If you have bone that you can anchor, of course, you should reconstruct with a bone. And the choice of flap would be a fibula. Uh, there are n number of reasons why a fibula is the most commonly used bone flap. Uh, would you just want to enumerate the most common, the most important reasons why we go for a fibula?
Sir, we can get adequate height or adequate length of the bone available for the reconstruction of the mandible, sir.
Right.
Uh, Second, the pedicle length is usually adequate for vascular anastomosis,
Mhm.
and
Most importantly, you can do multiple osteotomies, right?
multiple osteostomies can be done, sir. Yes, sir.
Osteotomies, and even if you're
With a
doing the
single.
yeah, having preserved the blood supply and doing the osteotomy, each osteotome segment will have its blood supply preserved, and you can plate them according to the angle that is required,
Yes, sir.
right?
Yes, sir.
Where a fibula actually does not help us so much is the height. So many times you'll have to do a double barrel kind of effect. Now, suppose you're resecting the condyle along with the lateral segment, then still would a fibula be your choice of flap, or would you want to do a soft tissue, or how do you go about it?
Sir, if we have resected the lateral segment and the condyle, then I would prefer to go with the soft tissue flap, sir. It can be a ALT flap or a pectoralis major flap, sir.
Okay,
We can go for a free fibula flap, sir, but we will have to cantilever the flap. And
correct. And you should always remember that if you're doing a cantilever and if your masticatory complex, majority of your masticatory complex is gone, then the mouth opening is dependent upon the function of the opposite side. So if a patient already is having significant trismus, or if a patient is post radiation, post RT, with the mouth opening pre-surgery is already reduced, you in those cases you might want to select a soft tissue flap over a fibula graft. Shilpi ma'am, do you want to add anything to that, or if you have any other thoughts?
I think that is okay. And plus, we are having case presentations also. So there also we are going to discuss reconstruction.
Correct. Correct. Okay.
Sir, I
I
have
think
one question,
You
sir.
want to ask something?
Sir, when we should go for a oblique marginal mandibulectomy, sir?
correct. So an oblique marginal mandibulectomy is when you have a tongue or a floor of mouth disease, and you want to take a segment or at least the lingual cortex of bone for your margin. Suppose your mucosal margin is inadequate, and you want to take the lingual cortex of the mandible. So in those cases, we are either doing a sagittal marginal mandibulectomy, or like a sagittal split mandibulectomy, or an oblique marginal mandibulectomy, and that can be done only in the lateral segment of the bone. Remember that the anterior, the arch, the thickness of the arch, that is the space between the two cortices, is not as much as it is in the lateral aspect or in the body of the mandible. So if you are ever to do an oblique marginal, we always do it in the lateral segment of the bone. Suppose you have an anterior floor of mouth disease which is close to the mandible. If there is no significant paramandibular spread in that area, you can get away with a horizontal marginal mandibulectomy. Suppose there is significant amount of a paramandibular disease. In those cases, instead of doing an oblique marginal, it might be better to take the entire segment of segmental bone in that area.
Okay, sir. Thank you, sir.
I think otherwise, Shilpi ma'am, he has covered all the indications, everything well. I don't think there is much that we need to add to what he has said.
I just want to ask one question. If Vikas, are you here? I can't see his name actually. I saw him sometimes back. Hello, Dr. Vikas can join later. Otherwise, Nidhi, just please call him or just please
I'll,
accept
I'll,
permission.
I'll,
He joined and I have upgraded him to the panelist. I think very soon he'll be there.
Yeah. Okay, now he has messaged that got a call, so he had to log out. Now he's unable to join. So maybe now you have to upgrade him again.
I have upgraded, ma'am.
Okay. So again, I think because he logged out in between. So anyway, in the meantime, let me ask you one question, Dr. Rohan. So you mentioned in the routes of tumor entry, you mentioned almost all the routes. But have you heard of any other route which was thought earlier, which was described earlier, and over the period of time we have kind of totally disregarded that? Do you know any other route of entry to the mandible? Have you ever heard of the Polya, the German? Manchester, McGregor?
Yes, ma'am. No.
So basically, so now the most common theory is by latest given by Browns, which is the line of abutment theory. But there were other theories, and in the beginning, when all it started, that how the mandible is involved in oral cavity cancer, it was supposed to be involved by the lymphatics. So people used to think that the lymphatics from the tongue and floor of mouth cancer, they go through the mandible periosteum and then they go to the lymph nodes. That is why they initially, when they had started all this, they had removed mandible in each and every case, thinking that this is always involved. So that was through the lymphatics, and this was very, very early stages. Like I think in 1900 or two, there is some article by some German, Polya. And then after a few years, it was Marchetta who proposed that it is not through that, it is actually through the direct extension. So in tongue and floor of mouth cancer, if the mandible is not involved, you don't have to do mandibulectomy for each and every case. So, and then there, after a few years, then there was a proposal that it is through the occlusal surface. This was, I think, given by I don't remember exactly, but I think it was McGregor. And then came the Brown theory. So
through the
now, in
occlusal
your
part of the.
experience, so tell me, which is the most common route of entry? Is there
Ma'am,
any study? Is there any Indian study which has looked at it and has dictated that okay, this is the most common route?
There is a paper by Dr. Choker et al, ma'am,
Hmm.
for the invasion of mandible in in GBC cancers, ma'am.
Yes.
So, and the preferred route of entry in that study, it is shown that it is the occlusal surface. But the number of subjects in that study were quite less. Hence, the result were so
Exactly.
the occlusal surface were 14 patients and the point of abutment was 6 patients, which
Yeah.
Browns has described as the primary mode of.
Yeah. While in the Browns, it was line of abutment. And the other thing which we can consider, because our Indian patients, we are different from their Western counterpart, because here the mandible is not just involved as a alveolar carcinoma. They are basically buccal mucosa gingivo complex cancers. So because of the habit of chewed tobacco. So maybe in our setting, occlusion is more important than the line of abutment theory. But yes, this had a limited number of patients, so maybe we should look at the bigger number. Now, Dr. Vikas is here.
Yeah,
Vikas?
yes. Sorry, Dr. Shilpi, I
No
got
problem.
disconnected in between. So actually, I joined late also, but as far as the discussion has gone, it was pretty well. As far as the involvement of the alveolus is concerned, you have summed it correctly, that it was actually initially thought that the lymphatics are involved, and then Macheta came up with the theory that it's not because of that, it's the mandibular periosteum, which is the way station to the cervical lymph nodes. Then McGregor and McDonald actually they evaluated the cases of the irradiated and non-irradiated mandible, and where they were finally concluded that in cases the patients who have already received radiation, probably the marginal mandibulectomy in such cases is not recommended. One of the question which I wanted to ask Dr. Rohan is, what is the safe margin of the bone which you like to take when you're doing a segmental mandibulectomy?
And also in marginal, because there is also one question in the chat box someone has asked. So please answer for both.
And for marginal mandibulectomy, usually marginal mandibulectomy is done to get adequate margins. Means the mandible forms the marginal part of the bone forms the margin, and we should not take. And if the bone is eroded, which we have to take the margin, then usually we do a segmental mandibulectomy in those cases. And in bone, a margin of 1.5 to 2 centimeters should be taken as adequate margins mm, uh, for bony. If there is frank bony involvement, then we should take 1.5 to 2 centimeter margins.
Yeah. So there's an article by Dr. Chopra which
Yes,
says
sir.
that a safe margin of 2 centimeters is adequate on the bone actually. The another thing which I wanted to add actually for the reconstruction, now 3D printing is in a big way coming up. In our institute, what our plastic surgeons do is they reconstruct the entire mandible using the patient's CT scan, and the osteotomy cuts are also decided over it. Now the advantage of that is that the occlusions are better, and probably if we look into the data again later, probably it will help in better speech and swallowing too. So basically the entire mandible is 3D printed on a template, and osteotomy cuts are also decided pre-operatively. And intraoperatively, they provide us with the template and they tell us where exactly the osteotomy has to be done.
Yeah. So Dr. Roman, time we have already 7:11, so we are going to conclude this session. But I just want to ask one more question. Since you mentioned we are having the same discussion, that in your presentation you mentioned that in superficial erosion, in some select cases, you can do marginal mandibulectomy. So what is your experience? And if suppose you have to do, what precautions do you take pre-operatively that while selecting, that patient for margin?
We should be sure that there is no deep bony cortical invasion or marrow invasion in such a case.
Marrow definitely. Okay, marrow, yes. So how do you make sure?
By radiology, ma'am, by preoperative radiology, we should be sure that the mandible marrow is not in.
Yeah, so marrow is not involved, but how deep should be the erosion? Basically your imaging, how does it guide you? How can you select that, okay, this patient can go for marginal and this will not go? Is there any paper looking at that, or is there any figure given to select these kind of patients? Are you aware of any paper?
Sorry, no, I'm not aware.
So you must read this paper by Dr. Suprita Arya. She has looked at patients, what should be the vertical height of the remaining mandible if there is superficial erosion, and when you can attempt marginal mandibulectomy without compromising on the oncological safety. So as per her work, if the remaining height of mandible is 2.2 centimeter, that means you look at the complete height of the mandible, you measure the bone invasion, and then you take the margin of the normal mandible. If it is 2.1 centimeter, then still you can go ahead with the marginal mandibulectomy, because you have 1 centimeter margin for your margin, and then you have remaining length of the 1 centimeter, 1.1 centimeter, so that it does not fracture. So you should be very careful in selecting these kind of patients, and you have to be sure on radiology that yes, this is a candidate where I can do marginal mandibulectomy. Only grossly, just looking at the clinical picture, you should not decide.
Yeah, Shilpi ma'am, just like to add one point here. As you rightly said, that very superficial cortical erosion, select cases, we can go for marginal. Specifically, more so in those cases, we should be very careful if it's a purely alveolar disease, and it's going in through the occlusal surface. There is a cortical erosion, and through the occlusal surface, maybe we would be slightly careful. If it's a buccal mucosa disease just coming onto the cortex, maybe without any paramandibular disease, those cases we can still consider with the height is, as you said, more than 2 centimeters.
So I think it's time to conclude. Any other comment, Dr. Vikas, Dr. Harsh? Okay, thank you, Dr. Rohan. It was very nice presentation. And please be available throughout. In the end, also, if there is any question related to your topic, we will be asking questions. So now we move on to the second session, which is the case presentation by Dr. Sukirti Tiwari, who is fellow at Max Hospital. And the faculty for this session is Dr. Smriti Panda, who is the oncosurgeon at AIIMS Delhi, and Dr. Vinita Goyal, who is radiation oncologist at Fortis Hospital, Delhi. So over to you, Dr. Sukirti. You can start sharing your slides.
Good evening. Am I audible?
Yes, you are.
Okay. Is the screen visible, ma'am?
No, we cannot see the screen yet.
Ma'am, in this it is coming host disabled participant screen sharing actually.
Okay. Nidhi, please. Try again.
Ma'am, it's coming the same.
Okay. Nidhi, can you please look into it?
Yeah, ma'am, I'm checking because
Okay.
Yeah.
Otherwise, if you have the presentation, you can also start.
Showing that she can share the screen now.
Okay. Please try now. Yes, we can see it.
Okay. Good evening, everyone. I am Dr. Sukirti, robotic fellow, head neck oncology at BLK Max Hospital.
In the interest of time, Dr. Sukirti, I'll just ask you to comment on the relevant findings only, And
Okay, ma'am.
skip those general, details.
Okay, ma'am. Okay, so a 67-year-old male patient reported to us. He has no comorbidities. He was a government employee and the resident of West Delhi. Came with a non-healing ulcer present over the right lower alveolus since 1 month. Patient has given a history of dental extraction 1.5 months before, in which he noticed that the wound was not healing and it was progressive in nature, which was painless. Later on, he visited to his dentist, whom he has done his dental extraction. From there, he was advised to get the biopsy done. In that patient, there was no history of pain or the bleeding present, no history of numbness or the altered sensation over the chin, skin, or the lip, no history of fever, pus discharge, or any swelling, loss of weight and appetite. There was no relevant past medical surgical family history. Patient had a habit of smoking 25 years ago, which he has stopped, and he was an occasional alcohol user. The patient was a moderately built, moderately nourished, and oriented.
Dr. Sukirti, sorry to interrupt. This is Dr. Smriti. Before you move on to the examination, can we ask you a few questions?
Yes, ma'am.
Yeah. What does the presenting history tell you about that? He first presented with loosening of teeth, and then he noticed the ulcer.
Ma'am, he is a patient of generalized periodontitis actually. So he had already got his extraction done because of the loose teeth 1.5 months before. And then after the extraction, he noticed that the wound was not healing because this process was up to related to approximately 1.5 months, and the wound was even getting progressive. It was increasing in size. So he consulted. Yes, ma'am.
So apart from periodontal disease, if a patient is presenting with loosening of teeth and an ulcer in the same adjoining area, so what will that make you? Can you comment on the disease extension? What does that tell you?
Sorry, ma'am, I couldn't understand your question.
So if a patient is at presentation complaining of loosening of
Ma'am,
teeth,
when the patient reported to me, it was only the ulcerative finding. I got to know about the ulceration present all over his right lower alveolus.
so would you consider the possibility of bone involvement, mandibular involvement in this patient?
Yes, ma'am.
Going by the history, obviously we have the
Yes,
clinical
ma'am.
examination there.
We were expecting a bone involvement in that, and the patient has already got an OPG done, in which I have.
We'll come to the examination and the investigations later on.
Okay.
Let's focus on the history taking aspect. So, is there any other negative history that you could have asked over here? Pertinent to a primary located in the lower alveolus. Did he say anything about his mouth opening?
Ma'am, the mouth opening was sufficient. He has a good mouth opening of more than 35 mm.
Yes, but
there was no
trismus,
trismus present.
Okay, so if the patient had complained of trismus, so what would that indicate to?
Ma'am, there can be an involvement of masticator or the infratemporal ITF involvement, in which the muscles of mastication gets involved by the tumor, which will lead to the tumor in a locally advanced oral cavity cancer.
Any other reasons for trismus? And how would you?
Yes, ma'am. If the other reason for trismus could be because of OSMF, in which there was a fibrosis of the buccal mucosa.
Okay. And if patient doesn't have OSMF and on radiology you do not see masticator space involvement, patient still has trismus. Is that possible?
Ma'am, that is possible in a case if the patient is having a pain and he's not able to open the jaw because of the pain.
Yes, you can have pain and the surrounding inflammation can cause restricted mouth opening. So in such a patient, when you do an examination under general anesthesia, you can see that the mouth opening has improved.
Yes, ma'am.
Okay. And also in the personal history, so whenever you have a history of smoking,
Yes.
this patient has a positive smoking history.
Yes,
So
ma'am.
you can be, yes, so you're supposed to quantify it in terms of pack years.
Surely, ma'am.
So you were for the benefit of the audience, can you say how to calculate pack years?
Ma'am, I'm sorry, I won't be able to.
So one packet of cigarette contains roughly 20 units. So the number of packs smoked per day multiplied by the number of years. So one pack here would be smoking one pack per day for 1 year.
Okay.
Yes, please proceed.
May I also make a small comment? I am Dr. Vinita Goel. Am I audible?
Yes, ma'am.
So, Sukriti, when you're taking the history, as Dr. Smriti just pointed out, that you have to calculate pack years. In case your patient is a tobacco user, you have to give a detailed description of the use of tobacco also. And you have to
Yes, ma'am.
specifically mention if the patient was keeping the tobacco.
Tobacco in the same site.
Yes, and on the, they sometimes keep it at the night time also. So all that also needs to be mentioned. It is important to know about the pack years of smoking because if if there is a HPV related malignancy, then also there can be a history of smoking, but then the history of the number of pack years is little lesser as compared to non-HPV users. I think Dr. Smriti is trying to get you to a point that history, examination, and investigations should not be mixed. The examiner, in case you're appearing for a postgraduate examination, they will keep stopping you at the history because they would want to build up your case from the history itself.
Yes,
Yes.
ma'am.
So not to mention about OPG in that or about your examination findings. Yes.
Okay.
Very well. Please proceed.
Okay. The patient is a moderately built, moderately nourished, and oriented to time, place, and person. The performance status of the patient is ECOG 1. Vitals are normal, and all systemic examinations were done in which the respiratory, cardiovascular, and the CNS examinations were normal. Local examination, inspection. The mouth opening is more than 35 mm. Facial symmetry was present, is there. Ulceroproliferative growth was present, which was present over the right lower alveolus with missing teeth in the respective area. The size of the lesion is approximately 3.5 centimeter into 3 centimeter, which is irregular with irregular margins and everted base. The extent of the lesion is anteroposteriorly, it was extending from premolar region to just short of RMT, whereas mediolaterally, it is involving the gingivo-buccal sulcus and medially involving the gingivo-lingual mucosa. The tongue movement was normal. Prosthesis was present over the left lower molars and upper second molar. The generalized periodontitis present. Halitosis absent. No other lesion was noticed in the rest of the oral cavity. On palpation, all inspectory findings are confirmed by palpation. Lesion is tender on palpation, but no bleed on touch was there. Induration present, which was beyond the margin of the ulcer. No paresthesia was present over the cheek, skin, and the lip. On palpating the lymph nodes, there was no significant lymph nodes were palpable. Provisional diagnosis, 67-year-old male with no comorbidities with the ulceroproliferative growth over the right lower alveolus with no cervical lymphadenopathy, most likely malignancy of the lower alveolus, clinically T4A N0MX. In the
So based on
I think we stop here. We discuss it.
Yeah.
Sukriti. Yeah.
Sure, ma'am.
Dr. Smriti, start.
Okay.
Please.
Yes. Can you show your clinical photo, the oral cavity picture? Yes. So why have you staged this tumor as T4?
Ma'am, this tumor was lying just on the alveolar mucosa, on the alveolus. And we were given the history of dental extraction, which after the extraction, the disease has been progressed.
So, based on your history, there was loosening of teeth. And what is the status of the remaining dentition?
Ma'am, there was a generalized periodontitis was present. There were few teeth which were RCT treated with the periapical abscess were seen in the left lower molars.
So the teeth adjoining the ulcer, so were those loose as well?
A grade 1 mobility was there.
Okay. So in other words, like apart from loosening of teeth, so what are the features on clinical examination which points towards a possibility of mandibular involvement? One you have already mentioned, the mobility of the teeth. So something which is there in your patient as well. Sorry, you're not audible.
Hello.
Dr. Sukirti, yeah,
Yes,
are
ma'am.
you there? Yeah.
Yes, ma'am.
Yes. So what are the other features of possible
Ma'am,
mandibular involvement?
in this, there was when seeing the lingual mucosa, there is seen that there is a bulge present, which shows that the extension of the disease is beyond the level of the cortical plate.
Yes. So if you have soft tissue present on either side of the mandible, that is the buccal and the lingual aspect. So that is one feature that you should look for, and also expansion of the mandible. And
Yes.
what is paramandibular extension?
Ma'am, paramandibular disease is something which lies on the buccal plate or the lingual cortical plate of the mandible to the entire height of the mandible.
Yes, so it is the vertical extension of the spread with respect to your mandibular height. So
Yes.
if you have an extensive paramandibular spread, so does that have a bearing on your route of entry into the mandible? Like Dr. Rohan told you about various routes of entry.
Yes, ma'am.
So in the paper by Dr. Chalker, so when you have extensive paramandibular disease, so in those patients, it was seen that there were multiple routes of entry into the mandible. So that is something you should keep in mind. And also in your history, as well as in your examination, you have mentioned about paresthesia over
Yes,
the.
ma'am.
Yes, so what exactly are you looking for?
Ma'am, in this case, because this is a very close to premolar region, and after seeing the clinical picture, it shows that there is an erosion of the involvement of the bone. So we want to evaluate whether there is any involvement of the nerve, that is the perineural invasion in that. Because if there is an involvement of inferior alveolar nerve, then the paresthesia could be the presenting sign.
So where exactly will you check for the paresthesia?
Ma'am, over the lips.
Yes, so you basically check it in the mental nerve distribution.
Yes, ma'am.
Dr. Vinita, do you want to add?
Thank you, Dr. Smriti. I think the paresthesia should also be checked along the cheek and outer surface of the nasal cavity so that you get an idea about if there is perineural invasion along the mandibular nerve also.
Okay,
Okay.
ma'am.
Another thing that I felt was that there was a bit of a mixture in your inspection findings. First of all, you should mention about the findings which are very stark when you see somebody with an open mouth. For example, you mentioned about mouth opening. There itself, you mentioned about the tongue movement, whether there is any ankyloglossia or not. And there itself, you mentioned if there is any halitosis present or absent. Yes?
Yes, ma'am.
The other thing is, I wanted to ask, your examiners might ask you, how do you actually measure the size of the lesion in the oral cavity?
Ma'am, with the help of the extension of the disease in anterior-posterior direction,
How do you measure it?
by the help of a missing teeth, approximately the width of the teeth.
Okay. So the way we were taught how to measure the size is that the wooden spatulas which are used for depressing the tongue, they
Okay.
are placed over the lesion, and the area which becomes wet by which, and then you take it out and measure it on a scale.
Okay, ma'am.
You should never say in the exam that you will push the scale inside oral cavity. You can't put a scale inside the oral cavity. You will use a wooden spatula to measure it.
Okay, ma'am.
I also wanted to ask you, you mentioned about the mobility of teeth. How do you grade mobility of teeth?
Ma'am, it is mild, moderate, and severe.
Okay.
We have to check check the mobility of the teeth by taking into two instruments, that is the mouth explorers and the um, uh, mouth with the mouth mirrors
Okay.
back,
Understood.
by which if it is less than 1 mm, it is mild. It is less than 2 to 3 mm, it is if it is less than 1 mm, then it is mild. Till 2 to 3 mm, it is moderate. If it is more than that, it is considered to be the severe mobility.
Okay. Last thing from my side is that when you mentioned about the dentition, which Dr. Panda also asked you, you said that there was a diffuse periodontitis. That is fine, but you should still mention if the teeth were tobacco stained, if there are any sharp or angled teeth. Basically, you have to remember that you're dealing with a case of CA alveolus.
Yes.
It's likely that this patient will require surgery and later on radiation therapy. So accordingly, your dental planning, apart from the oncology planning, also has to simultaneously go on. So say,
Surely.
for example, suppose this patient has a sharp teeth in the upper alveolus on the ipsilateral side. Maybe you will consider extracting that also, because otherwise that will impinge on the flap later on. So
Yes.
describe it in better detail. So
Okay.
that's all from my side. You may go ahead with further presentation.
Okay. The routine
Dr.
implant.
Sukriti, sorry, did you examine the other subsites and sites of the head and neck?
Yes, ma'am.
I can only see the oral cavity examination. So your patient was a smoker, heavy smoker for the last 25 years.
No, ma'am. He
So-
was smoking 25 years back. He used to smoke. Right now, there is no history of smoking since last 25 years.
Are you aware of the duration of smoking? He
No,
must
ma'am.
have.
That was an occasional smoking which was present 25 years back.
So you are also expected to examine the other sites in the presence of a history of smoking, because you can have malignant as well as pre-malignant lesions in the oral cavity
Yes,
and
ma'am.
elsewhere
Yes,
also.
ma'am.
Yes, so you should screen the larynx, the oropharynx for possible second primary. It is not that uncommon, so you have to do a complete head and neck examination.
Okay, ma'am.
Yes, please. Yeah.
The biopsy was moderately differentiated as squamous cell carcinoma. In the radiology, there is an OPG which shows that there was a lytic lesion present over the right lower alveolus, where which is extending just superior to the inferior alveolar nerve canal, and which is extending from the level of the premolar region up to the angle of the mandible.
So these were the investigations that the patient presented to you with, or you did a biopsy and then advised for OPG?
No, ma'am, the patient presented with the biopsy as well as OPG to us. We did a PET
So-
CT for that patient.
So ideally, which investigation should be done first, the imaging or your biopsy?
Ma'am, ideally the imaging should be done.
Yes. And what kind of, like, how will you take the biopsy in this patient?
Ma'am, punch biopsy.
Okay. Would you not prefer a knife biopsy, which also includes some
Deeper.
amount of healthy mucosa, so that your pathologist can comment on the type of invasion? So it's better
Ma'am?
to do a knife biopsy. Yeah.
Yes, ma'am, incisional biopsy can also be done in that. Ideally,
Yes. Yes, ideally a edge wedge biopsy should be done
Yes.
rather than a punch biopsy, because punch you will take from a necrotic area, so it will be difficult for the pathologist to comment on invasion.
Okay, ma'am.
And from the look of the picture that you showed, this lesion does not look very suitable for a punch biopsy. It is a more of an infiltrative lesion.
Infiltrative lesion.
Although you called it ulceroproliferative, but mainly there is expansion of the alveolar mucosa and alveolus. It is infiltrative. So you need a knife biopsy or incisional biopsy.
Okay, ma'am.
What is the full form of OPG?
Orthopantomogram, ma'am.
How is it acquired? How is this X-ray done? Does the patient stand just like the way chest X-ray is done?
No, ma'am.
So orthopantogram is generally taken. There is a. It is like a. There is a. The X-ray tube rotates, makes a half circle around the patient, and then acquires the X-ray.
Yes, ma'am.
Please go ahead.
We have done a PET CT with contrast for this patient. This is an axial image showing the cortical erosion of the buccal and the lingual plate, and showing the breach of the lingual and the cortical bone in the right lower alveolus region, just extending from the first premolar region up to the angle. This is a coronal image which shows that the both of the remaining height of the mandible is seen in this, and the lesion is extending up to the half of the height of the mandible. A sagittal image of this patient shows that this is an inferior alveolar nerve canal, which is spared in this lesion. That is that the inferior alveolar nerve canal is running inferior to the surface of the inferior aspect of the lesion.
So Dr. Sukirti, we can discuss a bit of the radiology. So you have done right from OPG to a PET CT.
Yes, ma'am.
So can you show your OPG again? Yes. So what is the information that you can get from a OPG, and in which cases would it be not of much use to you? So in this, it's a yeah. So in this case, we can see the area of the mandibular erosion, and also we can see its relation with the inferior alveolar nerve canal. It is not a very sensitive investigation for seeing the mandibular invasion, because as Dr. Rohan had mentioned, you require at least 20 to 30%. Yes. Yes. So suppose you have a tumor located near the symphysis. So will OPG
OPG is not a good modality to check for the lesion in a midline.
Yes, because you have. Why is that so?
Because of the overriding, ma'am.
Yes, and also your spine would superimpose with the central arch of the mandible. So you will not pick up subtle erosion. So it is not a very good investigation for tumors which are extending to the central arch. And also, even if you don't have mandibular erosion, if you're planning a marginal mandibulectomy in a patient who is probably with some paramandibular spread. So it gives you an idea about how much residual height you will have.
Yes, ma'am.
And you have done a whole body PET.
Yes, ma'am.
So when will you do a CT and when will you do an MRI in case of carcinoma buccal mucosa?
Ma'am, CCT should be done in the cases of the buccal mucosa lesion. And basically, MRI is done in the cases of soft tissue, that is tongue if we want to see the perineural invasion and marrow enhancement.
So apart from bone erosion, what else are you trying to look for in your CT scan?
Uh,
Do you want
Ma'am,
to
the
look at
extent, the lymph
Sorry.
nodes.
Yes, yes. You also have to evaluate the status of the cervical lymph nodes. So if you have to do one investigation to look for bone involvement, so which is the most, so which investigation has the highest diagnostic accuracy?
Ma'am, CT.
Yes, it's the CCT with a puffed cheek.
Yes, ma'am, in which we can check whether there is involvement of the buccal mucosa.
Yes, so again, you can read the paper by Dr. Chalker, where they have compared various modalities to look for the extent of bone involvement. There is something called Denta CT. Are you aware of that?
Ma'am, I've heard of that, but can't
Yeah,
comment on that.
so it is very similar to it also gives you a panoramic view. So in that you can precisely see for the lingual and the buccal plate and look for minor cortical erosion. But the drawback is you don't get much information about the adjoining soft tissue component.
Okay, ma'am.
So whenever you do a CCT, you need to also look for the soft tissue involvement. And can you look for perineural invasion on a CT? Are there some indirect evidence?
Ma'am, there is widening of the foramen which can be seen on the CT.
Yes, the foraminal widening and also uh, direct tumor extension into the inferior alveolar canal, all that can be seen on CT as well. So if you want to assess the masticator space, so which would be better, your CT or your MRI?
Ma'am, for that MRI, we will prefer to have one MRI scans for the involvement of the muscles
Yes,
of
so
mastication.
yes, so you were listing out carcinoma tongue as an indication for MRI. So even in a gingival complex malignancy, if you want to look for the extent of masticator space involvement, you should get a contrast enhanced MRI as well.
Okay, ma'am.
So
Okay,
I
so
think
in this case,
you can kind of make a division. If there is a CA of the lower alveolus, maybe, especially in a node negative situation, maybe a contrast CT scan of the neck was good enough, and along with imaging for chest, and PET scan is not always essential.
Yes, ma'am.
But when there is upper alveolus, then it is better to do a MRI because you want to look at the infratemporal fossa extension or the masticator space extension. And you're also keen to know about, especially in the palatal lesions or upper alveolar lesions, where you want to know about the perineural spread. Then the sensitivity and specificity of MRI is more than the CT scan. In the MRI, you have to particularly look at the CIS sequence, CISS sequence, to see if
ma'am.
any enhancement along the nerves, to call it perineural invasion.
Okay, ma'am.
also you had in the last slide that you had shown, where you were mentioning about the alveolar canal involvement. So I would like to point out that this is the oblique reformatted sequence. So you're supposed to evaluate the inferior alveolar canal in this particular sequence.
Okay, ma'am.
And just a word of caution, please hide patients' names and details whenever you're making a presentation.
Sorry ma'am, for
It should
that.
not be visible. Yeah.
Yes, ma'am. Sorry.
I think you proceed.
Okay, ma'am. So the diagnosis is the squamous cell carcinoma of the right lower alveolus. And the treatment plan is the right composite resection, that is the wide local excision plus segmental mandibulectomy plus right SND level 1 to 4 plus reconstruction by the free fibula osteocutaneous flap.
So whenever you, after you have given us the diagnosis, it's always better to, before you say the treatment plan, you should always take the patient to a multidisciplinary tumor board because you have a stage 4 oral cavity cancer. So
Yes,
you are expecting multimodality treatment. So always the plan is made in a MDT.
yes, ma'am.
Sorry to interrupt. We have 5 minutes left for the presentation.
Okay. Okay, so what will be the extent of your segmental mandibulectomy, or in other words, what is the Brown's classification defect that you anticipate in this case?
This is a class 1 in which a lateral defect will be present.
Very good, yeah. So your condyle and coronoid can be preserved, and the probably you will have the defect up to the canine.
Yes, ma'am.
All right. So when you're doing your free fibula reconstruction, so would you be giving any consideration as to the dental rehabilitation of the patient?
Ma'am, in a straightforward sitting, we are not giving consideration for dental implants because as this patient has to undergo radiation as well. So, and after we have done few cases in which we have done the dental implants, but that should be, the patient should be of a disease-free, there should be a disease-free interval of at least 2 years.
Dr. Vinita, do you think dental implants would be a contraindication for adjuvant therapy?
Dental implants would not be a contraindication, but I agree with what she's saying, that we have to wait for radiation to get over and then the mucositis to settle down and make sure that patient is disease-free for a reasonable time interval before proceeding with this another major procedure.
So if you have not considered dental implantation per primum, so yeah, as you mentioned, it is a good idea to wait for the acute effects of radiation to settle down. And also there is a concept called join a day. In the interest of time, I'm not going into it. Maybe you can go back and read it.
Okay, ma'am. Dr. Smriti, in your practice, do you have any special considerations keeping in mind that, later on this patient may be eligible for dental implantation?
Yes, ma'am.
What do you do?
Ma'am, basically, there are few cases in which if the patient is young and we can do it and the segment of the bone is not too, the length of the segment is not too much, we have provided with a double barrel fibula as well, so that the height of the mandible can be attained.
Okay. Please proceed quickly.
Ma'am, that's it.
That's it? Okay, good. Very good job.
Thank you, ma'am.
One last thing, Dr. Sukirti, you will be addressing level 1 to 4. Why is that?
Ma'am, the lymph node metastasis to level 1 to 3 is up to 91%. In this, in our institutional practice, we prefer to do neck dissection till level 4. Otherwise, it can be up till level 3 as well because this is an N0 neck, and whatever data we have, it is very rare to get a skip metastasis in level 4 and 5.
Yes, so probably you're referring to the paper by Dr. Gauri Panpadya, which
Yes,
mentioned
ma'am.
that you hardly get any skip metastasis to level 4, and you do get skip metastasis to level 3, but those were for carcinoma tongue. So when
Yes,
you have a well lateralized lower alveolus lesion with no floor of mouth extension, probably you can address level 1 to 3, and also your ASCO guidelines also say the same thing.
yes, ma'am.
So after your surgery, so you would be planning uh, adjuvant treatment also. So
Yes.
that should be incorporated in your treatment plan.
Yes, ma'am.
Thank you, Dr. Sukirti. Excellent presentation. And I thank Dr. Smriti and Dr. Vinita for excellent moderation and discussion. Now we move on to the next case presentation, which will be done by Dr. Rachit Sood, who is also an MCH resident at AIIMS, New Delhi. And the faculty for this will be me and Dr. Vinita. So Dr. Rachit, quickly please start sharing your screen.
Yes, ma'am. Ma'am, can I be made the co-host? I'm unable to share screen.
Nidhi, please do that.
I've done that, ma'am.
Okay.
Okay. Ma'am, is it visible now?
Yes, we can see.
Good evening, respected all. I'm Dr. Rachit Sood, and I'll be presenting the second case for today. My patient is a 52-year-old male resident of Uttar Pradesh who is a laborer by occupation. He presented to us with chief complaints of dental pain in the right lower jaw for the past 4 months and a non-healing oral ulcer in the right lower jaw for the past 4 months. The patient was apparently asymptomatic 4 months back when he started developing pain in the right lower jaw. It was insidious in onset and it aggravated on chewing and was partly relieved with some oral medications. It was also associated with a non-healing ulcer in the right lower jaw, and there was history of loose tooth for the past 2 months. The patient had no history of any oral bleed, no history of decreased mouth opening or reduced sensation in the cheek or the lower lip. He gave no history of other similar lesions in the oral cavity in the past. There was no history of difficulty in swallowing, difficulty in breathing or change in voice, no history of cough, hemoptysis, pain in the abdomen, jaundice or any bony pains, and he gave no significant history of weight loss. Coming to the addiction history, the patient had a history of tobacco chewing of 1 pack per day for the past 5 years and a 5-pack year cigarette smoking history, both of which was reformed 4 months back after he had developed pain and the loose tooth. There was no significant family history. Coming to the past history, there was no history of any hypertension, diabetes, bronchial asthma, any other comorbidities, and he had no known allergies. Coming to the treatment history, he had no treatment for this complaint in the past and had no significant and no history of any previous surgeries.
Go ahead.
Please go ahead.
Yes. Coming to the general physical examination, his general condition was fair. He was conscious, cooperative, and well oriented to time, place,
Is
and
there any
person.
abnormality in the
No, ma'am. The general
Then
physical
skip.
examination, systematic examination was normal.
Okay, then skip. Come to the local examination.
Coming to the local examination of the neck, on inspection, the neck movements were normal. There was no visible swelling, no scar, sinuses, fistulas, or any dilated veins. On palpation, the inspectory findings were confirmed, and there was no palpable swelling or lymph node. The trachea was central. Coming to the local examination of oral cavity, his mouth opening was adequate, was admitting 3 finger breadths, and the interincisor distance was 4 centimeters. There were no sharp tooth or dental caries. The mandible was dentate and had a poor orodental hygiene with nicotine-stained mucosa. The right lower first to third molar were loose, and there was an approximately 4 into 2 centimeter ulceroproliferative growth that was present in the right lower alveolus. Posteriorly till the third molar. Medially, it was involving the lingual aspect of the mandible. Laterally, it was involving the lower gingivo-buccal sulcus, and the overlying skin was free. The retromolar trigode region was free. The lesion was far from midline, and there was no induration in the overlying skin. The lesion was also far from the upper gingivo-buccal sulcus. The tongue movements were normal. The base of the tongue was soft, and there was no growth or any induration seen in the tonsil, posterior pharyngeal wall, or the soft palate. The laryngoscopic examination was normal, and the remaining examinations were normal. Summarizing my case of a 34-year-old male laborer with no known comorbidities, with non-healing oral ulcer and dental pain for 4 months and loose tooth of 2 months. with a 5-year addiction history of tobacco chewing and smoking, with a 4 to 2 centimeter growth in the right lower alveolus from the canine till the third molar, associated with loose tooth, overlying skin being free, and no palpable cervical lymphadenopathy. My provisional diagnosis would be a malignant neoplasm of the right lower alveolus, clinical staging T4A N0M0.
How do you define reformed smoker? You mentioned the term.
Ma'am, smokers, according to NCM guidelines, can be either currently smokers who have smoked a cigarette within the past 30 days, no? And former smokers who have not smoked a cigarette for the past 30 days, how they have defined.
And why do you think that it is T4?
Ma'am, 2 reasons. One, the presence of loose tooth, and the other, the growth being on both
both
the
sides.
gingival surface and the lingual aspect.
Okay. So how do you investigate this patient?
Ma'am, I would first, after history and examination and fiber optic laryngoscopy, I would want a imaging to be done first in the form of contrast enhanced computed tomography, the extent of which would preferably be from the base of skull till the T12, that is the diaphragm, and following which I would want a histopathological examination in the form of a biopsy. The
And to
biopsy for
do
this patient was
before
small.
is, will you always do imaging first, wait for imaging to come and then do biopsy, or you can do it anytime?
Now, a biopsy first would lead to a lot of quite a bit of inflammation, and imaging within a small period of time might overestimate the disease.
What kind of inflammation it is going to be? This is a proliferative lesion. You are
Yes.
going to take what you are going to take. You are going to take excision biopsy.
No, ma'am.
Oh, no.
Take
So
a
you're just
wet
taking a
biopsy.
small piece. So you
Yes.
can do simultaneously also. You can even take. So if you talk to a radiologist, it really does not matter because you're taking only a small piece. It is not going to change, significantly. You're not doing a major incisional biopsy or excision biopsy, which is going to change the picture. So
Yes,
you
ma'am.
can do. So best would, but yes, there are some examiners who would like to listen to this explanation. So best would be not to, go into this detail because best is just to say, I would like to do imaging, I would like to do biopsy. If they further ask you, then probably you can say, okay, you can, say that. But
Yes.
best would be to avoid all these things, that this will be followed by this.
Yes.
Because practically it really does not make much difference.
I think your presentation so far has been very crisp.
Yes.
You nicely mentioned that you will do a, contrast enhanced computer tomography from base skull to this vertebra. You forgot to mention that it will be with puff cheek technique.
Yes. Sorry, ma'am. Yes.
Second thing is what are the things which you are going to look for in CT scan and for this particular patient?
Ma'am, first I would like to look at the primary site for the extent of the lesion. I would also look at regional site for any cervical lymphadenopathy. And also I'm incorporating till the diaphragm to look for any distant metastasis.
No, primary may what all you are looking. What are basically what you are trying to look? It is lower alveolus.
Yes.
Clinically it is extending from which area to which area, but still you have done imaging. So what do you want to see?
Ma'am, I would like to see what are the planes with the masseteric muscles and the medial pterygoid muscle that can also upstage the disease.
So basically you want to see whether the masticator space is involved or no. You want
Yes.
to see whether the infratemporal fossa is involved or not, right?
Yes. Yes, ma'am.
What is the difference between masticator space and infratemporal fossa? Or they are the same?
Ma'am, they have been used interchangeably, but they are not exactly because the specifically the masseteric muscle forms a part of masseteric space, but not the part of infratemporal fossa as its content.
So suppose I say that this patient is having ITF involvement. Now, what extra thing which you would look for?
Ma'am, I would like to look whether the extent of the infratemporal fossa involvement is below the notch, or is it above the notch, and would like to classify it into a low and a high infratemporal fossa.
Okay. Is there any other classification apart from this low and high?
Then there's also a classification by Mahajan et al., where he has divided the ITF into 3 compartments. The first being the low ITF, which involves the masseter and the medial pterygoid. The second being the anterior high ITF, which involves the retroantral fat space. And when the posterior high ITF is again divided into 3 components, into A, B, and C. A being temporalis, B lateral pterygoid, and C being the neurovascular component of pterygopalatine fossa also.
Okay. And is there any other classification apart from these 2? More simpler than what you just mentioned? And probably more relevant?
Liao et al. Being supranotch in front.
Yeah, so Liao and this Mahajan, and there is third one by Dr. Nirav Trivedi. That
Yes.
also you should read because that is more practical as a surgeon. And so there he has divided into 3: low, intermediate, and high ITF.
Yeah,
So high is basically if it involves your pterygomaxillary fissure and your intracranial compartment. So they have very poor prognosis. So that is why probably the surgery is not the right thing to do. And for low and mid, you can still operate. Any other thing on imaging?
Ma'am, I would like to also see the extent of mandibular erosion, although on clinical examinations is evident, but I would like to see there's any inferior alveolar canal involvement or any marrow infiltration.
What if there is a marrow infiltration?
And the management
Does it change?
No, ma'am. The staging and the management would be the same.
Would you like to do something else? If suppose your radiologist says that the marrow is completely infiltrated, would you like to do anything else for this patient, or you are okay?
Ma'am, the plan would remain the same. I would want to look at the periannular invasion.
So would you like to order any other investigation?
There are subtle signs on the CT as well, but I would want an MRI to look for periannular invasion and marrow infiltration.
What is perineural spread and what is perineural invasion?
Ma'am, perineural spread is a clinico-radiological term, and a periannular invasion is a histopathological diagnosis.
Yeah, so when we are talking about pre-operative imaging and all, it's better to use perineural spread than perineural invasion.
Yes.
Very nice.
Okay, Dr. Vinita?
No, I'm happy. Very good discussion. Please go ahead.
So then, okay, so what have we decided for him? We have done imaging, it's biopsy, it's T4, N0, M0 as you have decided. Now what will you do? How will you go ahead?
Ma'am, I would counsel the patient about the staging of his disease and the management options. And my treatment intent would be a curative intent. And depending on the radiology, would like to see how much far away it is from the skin.
That you have done. You have planned your reconstruction, whatever. Now you tell me what you are going to do for this patient. Patient is on table, or you have decided what you are going to do for him.
I would first, for the primary, I would want a composite resection. I would plan a wide local excision with a right side segmental mandibulectomy. And since it is an N0 neck, I would want to do a selective neck dissection from levels 1 to 3. For the reconstruction, I would prefer a osteocutaneous free fibula flap.
Okay, now first the resection. What will be your skin incision? Cheek approach, right? But where will you place the incision for this particular patient?
I would prefer a Robson lip split that would be near the commissure, and then extend it into the neck till the level of
angle split is skin incision you will prefer. Why not midline split?
Ma'am, for posteriorly based lesions, maybe for the lesions which are located in the RMT region, I would still prefer a midline split.
Why?
Why so? I want to vascularity of the right side, And for the lesions which are approaching near the oral commissure and more anteriorly based lesions, I may not be able to preserve the inferior labial artery, and the facial arch will not be supplying that part of the lip.
But
That's
this
why,
patient is in the GBS, no? Lower alveolus is GBS, buccal mucosa is free, no?
yes, ma'am.
So then what will be your preferred approach? What will be more functional, to preserve the commissure or not to preserve the commissure?
Ma'am, preserving commissure would be better in terms of
Why
functional.
you are saying like angle split in this? You can do midline split also, no?
Yes, ma'am.
So basically you have to see whether is there any surrounding leukoplakia, erythroplakia, unhealthy mucosa. So angle split can be given in each and every patient. You can always do it because it is the most safe technique.
Yes.
But midline split, you will give only in select patients when you know that you are not cutting, the inferior labial artery as well as you are giving the midline. So because that area will become watershed area and the skin may necrose. Okay, so in
Yes.
this patient, because you are far away, your buccal mucosa is going to be, you are going to get good margin, still preserving the blood supply. So you can give midline split.
Yes.
Okay. Fine, you have done composite resection. Suppose the patient says that he doesn't want to take the risk of re-exploration for free fibula and he wants to go for the alternative option. What are the options available?
Ma'am, apart from the free flaps, I would offer him the choice of a pedicle flap, which can also give him bulk. The choice of flap would be a pectoralis major myocutaneous flap.
Okay. So you have done pectoralis major myocutaneous flap. Then now patient has well healed, you have done everything. Post-op day 7, what will you advise the patient? Or what extra, would you like to do something else? Or what are the difficulties patient is going to face? Specifically in relation to your mandibulectomy and PMMC, I want to know. Because we don't have much time, we have lots of things
yes.
to discuss.
Ma'am, the mandible would tend to deviate towards the resected side in post-operatively.
Why it is so?
Ma'am, because of the unopposed push of the
Yes, you're right.
and
Unopposed
I would
action of the masticatory muscles.
yes, ma'am.
Then what will you do? Can you do something to prevent it? Have you ever heard of guide bite prosthesis or guide flange prosthesis or
Yes, ma'am.
guide plane prosthesis?
Yes, ma'am. They will help in rehabilitating the patient in terms of occlusion of the upper and the.
So how does it work?
Not sure.
So you have to read about it. This is a very important part of rehabilitation. And is there any way that you can measure the deviation of mandible, which happens? You know how to do that?
No, ma'am.
So you can even do that. You can, so basically you have to see, you have to draw a perpendicular line between the central incisors. Okay, and then you see where is the central incisor of the mandible. So from the upper and mandible, how much is the deviation that you can measure, so that you can, kind of get an idea how bad or how aggressive the patient needs, your physiotherapy and this prosthesis and all. So when do you put GBP or guide bite prosthesis or guide plane prosthesis? Which date?
Ma'am, it would be around 2 weeks from the primary surgery.
Suppose the patient has developed OC fistula, would you still give it?
No, ma'am, it would be only after the wound has completely healed that I would want to place that.
Or will you wait for patient to finish the radiation therapy and then you will advise him to undergo?
Ma'am, I would want to do it before the radiation, because post-radiation patient will also might have reduced mouth opening.
Okay, very good. So guide bite prosthesis is to be begun once the healing is completely, it has taken place, and you know whether your patient is not going to develop any OC fistula, patient started taking orally. then you should give it, but you should not delay it further, because otherwise the fibrosis and all will set in and it will be more difficult to correct the deviation of the patient.
Yes.
And how do you give it? And what does it do?
Ma'am, it helps in aligning the occlusion.
Where the patient has to apply it? On the operated side or on
Uh,
the opposite side?
Ma'am, it is on the opposite side.
Opposite side. Okay. Fine. Okay. You have seen the histopathology report, suppose, and so what are the, now I would ask Dr. Vinita to take over. So basically we want to know the indications of adjuvant treatment.
Yes. Rashid, go ahead. Who is the patient who will require adjuvant radiation therapy, and who is the patient, in your opinion, who will require a combination of radiation and chemotherapy after surgery? What are the indications?
Ma'am, I would want to see for certain parameters in the histopathological examination report. The main, primarily, I would see the size of the tumor and the T staging and the nodal staging both. The indications for adjuvant chemoradiation would be the presence of positive margins or any extra nodal extension. These are the two indications of adjuvant chemoradiation. Apart from that, ma'am, adjuvant radiation would be for stage 3, stage 4 tumors in the presence or if there are closed margins, or if there are more than one lymph nodes that are metastatic.
So very well said. But apart from the size of the lesion, you also have to pay attention to the factors like depth of invasion.
Yes, ma'am, depth of invasion, perineural invasion also. For depth of invasion more than 5 millimeters also, ma'am, I would want to give for adjuvant radiations.
There are some well accepted indications for adding radiation therapy, and there are some indications where there is still some debate over them. For example, suppose you have a patient where the lesion size is small, there is no invasion of the bone, say a lesion measuring 2.5 centimeter, depth of invasion of 5 millimeter, or maybe up to 7 millimeter. Margins are clear, nodes are negative, but PNI is present. Then you will discuss in multidisciplinary team, because these are soft indications for adding adjuvant radiation therapy.
Yes, ma'am. I
But-
would also see, yes, ma'am.
Yeah.
Also,
Always
what is the evidence for it? What are you basically all these things based on which?
So first of all, tell
For
the
the-
evidence for concurrent chemoradiation.
Ma'am, for concurrent chemoradiation, the evidence is from the 2004 Bernier-Cooper trial of EORTC 22931 and RTOG
Yes, very good.
ATOG number
950.
950. Good.
The European and the one in the United States, ma'am, those two trials.
So the meta-analysis of both the trials showed that the benefit of adding chemo and radiation therapy together is only in patients who have either positive cut margin and who have extra nodal extension. May I
Yes.
understand from you what is positive margin and what is negative margin?
Ma'am, actually, in this trial, the definition of positive margin was different in EORTC and in RTOG. Whereas in RTOG, the definition of positive margin was the presence of tumor at the surgical margin, but in EORTC, it was within 5 millimeters of the tumor. The tumor was within 5 millimeters. They had defined it as positive margin. But for now, ma'am, accepted definition is the tumor being within 1 millimeter of the resected margins.
Is considered positive.
Yes, ma'am.
Okay. And what is focal perineural invasion and what is diffuse perineural invasion? Or what is small nerve PNI and what is large nerve PNI?
Ma'am, in perineural invasion also, I would want to look at certain features such as whether it is a single foci, multiple foci, whether it is involving a small nerve of less than 1 millimeter diameter or more than 1 millimeter, and
Intratumoral or extratumoral?
What is the significance of this?
I think Rachit is not audible now.
I guess he's lost.
Mm.
Dr. Rachit? Dr. Rachit, can you hear
yes,
us?
yes, ma'am.
So what is the significance of focal versus diffuse or large nerve PNI?
Ma'am, a large nerve PNI would be more aggressive, and just the presence of that would also, although not a definitive indicator, but would be a soft indicator for giving adjuvant therapy even in early stage, stage 1, stage 2 diseases.
So just tell me one thing, since we discussed margin, can you just quickly tell us the margins, not in RTOG and this thing? Otherwise, how do you define margins?
Yes, ma'am. The margins can be either clear, close, or positive. More than 5 millimeters of pathological margin is defined as clear, and 1 to 5 millimeters are closed, ma'am, and within 1 millimeter is defined as a positive margin.
This is by what criteria? So 5 is considered clear margin. 5 millimeter more as per the Betsaki's criteria, which is most commonly used criteria. 5 is not considered close. It's less than 5. Between 1 to less than 5 is considered close margins. And of course, there are other, there are a lot of classifications, like they say, even if the leukoplakia is at the margin, that's also considered positive, but that is not widespread. It's not followed everywhere. So the most important is what you're saying, but 5 or more is considered clear margin according to most of the publications.
Okay.
Second thing is there any difference with the bony margin? Or you follow the same criteria?
Same criteria.
More or less the same criteria. Is there any way during the surgery by using frozen section, we can comment on bony margin?
Ma'am, we can send the marrow for frozen, or bony. We won't be able to decalcify, but marrow can be sent for frozen. The cut end at marrow from the cut edge of the specimen.
Yeah, that can be sent, and that is useful in select cases where you are testing marrow infiltration, or if you are dealing with re-radiation or redo cases. There it is helpful, and it should be done because sometimes you get tumor cells foci.
Okay, sir.
Okay. So
I think for the wider audience, it is also important to understand that we don't have to look only for mucosal margins or bony margins. We also have to pay equal attention to the soft tissue margins.
Yes, most
Because
important.
oral cancers have a lot of submucosal spread.
Yes, sir.
Correct. So when do you start radiation therapy?
It has to be read, line by line. It is always a good idea to have a discussion with the pathologist, discuss in the MDT. Yeah.
Yes, ma'am.
So when do you start radiation therapy? What is the timing?
Ma'am, ideally would want to start the radiation as soon as there is satisfactory wound healing, but preferably within 6 weeks. Also, ma'am, the whether the patient is able to complete, or if there is any interruption, or if the patient is defaulting, I would also want to know the when the adjuvant is completing for a total of treatment package time. That would my target would be to keep it within 100 days from the date of surgery till the last adjuvant.
That will be more than 6 weeks, no? So 100 days, if you have 6 weeks of adjuvant therapy and you're starting at 6 weeks, then it's more than that, right?
Yes, ma'am.
About 8 weeks. So who said that it should be 6 weeks?
Sorry, ma'am.
So there are 2-3 things which you should read. I think it's Angatal who said that 6 weeks is the optimal time, and if you stretch it beyond, then the oncological outcomes are inferior. But I think it was Bhadrasen who first commented that it should be 7 weeks. And then there are this by Rosenthal, that's 100 days treatment package time. So if you see roughly 6 to 8 weeks is the optimal time where you should start radiation therapy. If you go beyond 8 weeks, then the outcomes are inferior. So 6 weeks, yes, ideal, it should be started. But suppose you have some complication, or there is a OC fistula and all, you want to wait. So it's okay to wait till 8 weeks also, because we have evidence for that as well.
Yes, ma'am.
So I think it is always best to give a range in the exams. That generally we say that we aim to start post-operative radiation therapy 4 to 6 weeks from after the surgery. In case there are any healing issues or any complications, then up to 8 weeks is still considered acceptable.
Yes, ma'am.
And we don't call it package time, huh? We call it overall treatment time.
Yeah.
Yeah. So I agree with you that it was given by Vikram Bhadrasen.
But
This concept of overall, because it impacts the overall survival of these patients, and that is why there is always a hurry to start radiation therapy.
Yes, ma'am.
for this patient, what would be the dose of radiation? What would be the type of radiation?
Ma'am, if the margins are clear and
You know, this is T4N0 clear margin.
yes, ma'am.
So
Ma'am,
P4N0.
Pardon, ma'am.
Pathologically, it
Yeah.
is T4N0.
Yes, ma'am. Ma'am, the preferred mode of radiation would be an intensity modulated radiation therapy with a total dose of 60 gray divided over 30 fractions, 2 gray per fraction.
Literature, can you quote any study?
And there is a paper by Lester Peter also who had compared the different doses of adjuvant radiation.
What did he say?
I'm not sure about this.
Yes, so you're right. It's Peter and Ang who said that if you go beyond 66 gray, it is not much of benefit. So usually we give 60 gray, and then if there is a positive margin of you have to give some boost for E&E and all, we go up to 66. Dr. Vinita, is it right?
I agree with you that, the most acceptable dose is 60 gray in 30 fractions. And as the dose increases, the complications increase. So that is why even if we have to give a boost up to 66 gray, then it is to a very localized area. What is very important is to say that the radiation therapy will be directed to the right alveolus, buccal mucosa, as well as to the ipsilateral neck. Right neck nodes would be treated. Somebody can ask you that why do you want to treat neck nodes? Especially because pathologically these nodes are negative. However, there are ample of studies which have shown that there can be some still microscopic disease in the neck nodes, and it is a common pattern of failure to have neck nodes in the ipsilateral level. So level 1 to level 4 are generally covered. And you rightly said that radiation therapy has to be given with IMRT technique. But may I ask you what is the advantage of giving radiation therapy by IMRT, and why not 2D radiation therapy or 3D radiation therapy? What is the advantage that we are looking for?
Ma'am, we can map the disease and we can deliver altered different doses to at risk, high risk areas, and it would deliver comparatively lower doses to neighboring structures, leading to less number of adverse events, and like to the parotid gland, which is
So the mucositis would be reduced. The
Yes.
key side effect is mucositis. That would be reduced with IMRT as compared to 2-dimensional and 3-dimensional radiation therapy. Even with 2-dimensional radiation therapy in a localized lateralized alveolar mucosal cancers, you can save the contralateral parotid, which you can do with IMRT. But in 2D or 3D era also, we were able to do that because we were directing radiation therapy only to the ipsilateral face and neck.
What is IGRT?
IGRT is image guided radiation technique.
How it is different from IMRT is also image guided, no? We do CT scans.
Yes,
We
ma'am, we
do-
do imaging.
So how it is different from IMRT?
Ma'am, we do imaging and redefine the in the middle of. I'm not very sure about it.
So very good attempt, Rachit. I did not expect that you would answer this. So IMRT is intensity modulated radiation therapy. That is the way of planning radiation therapy. So as Shilpi asked, we do imaging for planning radiation therapy, modulating its intensity, defining target, etc. But in IGRT, we do IMRT, but every day before treating the patient on the linear accelerator itself, We take another check CBCT, check
Yes, sir.
cone beam CT scan, verify patient's position, and then do the treatment. That is called IGRT. What you were trying to say is called as adaptive radiation therapy. You said that, suppose in the middle of the treatment, patient loses weight or the flap shrinks or there are any, errors in the setup and we have to replan, then that is called as adaptive radiation therapy.
Okay.
Very nicely explained.
Good attempt, Rajat.
And do you also know what are these gross tumor volume, PTV and CTV?
Ma'am, there are three volume. One is the gross tumor volume, then the clinical target volume, and then the planning volume.
Planning target volume.
Planning target volume, ma'am.
Excellent.
Yes, ma'am.
What are these?
Ma'am, the gross tumor volume is incorporates the main at-risk areas, and the clinical target volume takes extra of 3 to 5 millimeters of adjoining risk area. Then the planning volume is for the movements in the head or the errors in from the planning to the delivery of the
And
radiation.
luckily we have Dr. Vinita with us. So ma'am, please
Very
explain.
nice, very nice. Gross
Yeah,
tumor
yeah.
volume, as you rightly said, refers to the gross disease. Gross disease in the alveolus, gross lymph nodes, which can be identified either clinically or radiologically.
Mm.
Now, clinical target volume refers to the area where we suspect that there will be a microscopic extension of the disease. So, which is generally defined by adding a margin to the gross tumor volume. This margin can vary from 5 millimeter to 10 millimeter, sometimes up to 20 millimeter also. In a patient who has already undergone, for example, suppose this patient you operate and send the patient to radiation therapy department, there will be no gross tumor. There will be no GTV, right? Because you would
Yes.
have anyway removed it by surgery. So there will only be clinical target volume. We would anticipate that, the area where the flap is, where it was the adjacent area of retromolar trigone, adjacent area of mandible, infratemporal fossa, ipsilateral neck nodes. These will be defined as clinical target volume or CTV. And they are further divided into high risk or low risk, depending on whether, like, for example, if this is the patient, then high risk CTV will be the ipsilateral alveolus and the flap area, while the neck nodes, because they are pathologically negative, will be low risk CTV. They will be given a lesser dose. For every CTV, even if we are doing IGRT, everyday IGRT, we still have to add a certain margin for setup error in the positioning of the patient, which is called as PTV or planning target volume. It is the safety margin which is given over CTV and usually is 3 to 5 millimeters.
Okay.
I think it's already 8:29 and we have 3 more questions also to answer. But quickly, just tell us what are the various types of radiation therapy regimen or types of radiation therapy, maybe.
Yes, ma'am. Ma'am, there can be the conventional, apart from conventional, there can be altered fractionation. That
Tell us
can,
what is conventional.
ma'am, conventional would be delivering a total of 70 gray, ma'am, and 2 gray per fraction over a period of 46 days, ma'am. Total duration of radiation.
35 fractions.
35 fraction, 70 gray, 35 fraction, 2 gray per fraction in 46 days.
So
30
generally,
to 35 may vary depending upon whether you are giving adjuvant or definitive, right?
Yes.
So it has to
Yes,
be how much gray per fraction,
per fraction.
how many days a week,
Yes.
correct?
Yes.
You have to, and whether you give 1 fraction per day or
Mm.
multiple fraction per day. That will
Yes,
be
ma'am.
conventional standard fractionation.
If the total duration is lesser than 46 days, then that is accelerated. And if the number of dose per fraction is less than 1.8 gray, 1.8 gray, less than 1.8 gray per fraction, then that is hyperfractionation. Ma'am. If it is more than 2, it is hyperfractionation.
no, no, no.
And a bit
No, no, no. I think this is not
very
correct.
confusing,
Let
huh?
me clarify.
Yeah.
1.8 to 2 gray per fraction, 1 fraction per day, 5 fractions a week. This
Yes.
is all put together called as conventionally fractionated radiation therapy. In accelerated radiation therapy, what we do is, suppose I give 6 fractions in a week instead of 5. Then that is pure accelerated radiation therapy. The other form of accelerated radiation therapy can be concomitant boost. I give 2 gray to a particular area, 2.5 gray to a particular area. That is concomitant boost. Hyperfractionation is I reduce my dose per fraction from 1.8 gray, I come down to 1 gray, 1.2 gray, and give 2 fractions in a day. Hyperfractionation, more fractionation. But then I'm giving 2 fractions in a day at a gap of 6 hours each. So that is called as hyperfractionation. Then there is something called as hypofractionation. For example, suppose it's a palliative situation and I decide to give 40 gray in 16 fractions. Less number, reduced fractionation. Less number of fractions. Then it is called as hypofractionated artery. Little bit complex.
Yeah, but you have to read, you have to know this. And also all the important trials like March meta-analysis, McKenzie trial and all, we don't have time to discuss and all, but you should know these things.
Another
Anything
thing I
what
think
we should,
all of you should know is that in case these patients are not eligible for cisplatin or carboplatin,
that's also very important
yeah,
discussion.
yeah. Then now there is an option of giving them docetaxel, concurrent docetaxel based on a recent trial which came.
So I think, Dr. Vinita, we should just address the questions quickly. There are 4-5 questions, repetitions maybe. But thank you, Dr. Rachit. Very well presented.
Thank you.
So there is one question, and this is addressed anybody. I request Dr. Harsh, Dr. Smriti, and Dr. Vikas, Dr. Vinita to please pitch in and answer, whoever wants to feel like. So there is one question: in marginal mandibulectomy, what is the specific margin given? I think this was addressed. So how you take normally what you take, so marginal mandibulectomy is not done for gross bony erosion. So it's basically for the margin. So sometimes even the 5 millimeter is enough. So 5 millimeter on histopathology, but bone doesn't shrink. So if you want to be conservative, if you are getting just 5 millimeter, 6 millimeter, it's fine. It's better to take on the safer side 1 centimeter like we always do. But more important thing is that you should have remaining height of at least 1 centimeter. Rather keep it 1.1 centimeter so that it should not become less and the bone should not fracture. That is most important. And then whatever you get, and normally you will get, if you take 1 centimeter, you will get a satisfactory margin. Then this was Pacquier, which was discussed. And why history of dental extraction is important. Dr. Harsh, are you there? I think Harsh is not there. Dr. Smriti? I think she is also left. So why it is important? First of all, because suppose there is already a carcinoma in the lower alveolus and you have done the dental extraction, you have opened one area, one passage for tumor to go in. So usually they tend to be more aggressive and it's kind of you have made another portal of entry. So that is why it is important to know the history of dental extraction. Exfoliative cytology may be helpful. No, exfoliative cytology is not considered a good option nowadays. This has high false positive and high false negative results. So it should not be done. Even if exfoliative cytology is positive, we do formal biopsy before starting the treatment. And many times this is falsely negative. And yes, reformed smoker definition. I think it is not 15 years. Reformed smoker is, like he mentioned, as per the NCCN, it's 6 months, but I think it is 1 year. Probably 1 year, but if NCCN has changed, then I'm not aware, but we have to check. Dr. Vanita, any idea? I think it is 1 year if he has not smoked.
I'm not sure. I don't know.
So this we have to see. And these are very important questions, favorite questions of examiners. Some examiners, they love to ask these questions. So that all the definitions, current smoker, heavy smoker, light smoker, one should be aware of. That's it, I guess. Any other question or any other question which we have left, or Dr. Vinita, if you feel that they should know from, especially from the radiation point of view, because they will be appearing for the exam.
So I think Dr. Roy has correctly mentioned in the question answer sessions that the mucositis is low, as has been shown by the passport trial. So it is a good idea to read this passport trial also.
Yes, passport.
The level 1 evidence for using IMRT in neck cancers.
And nowadays, all those you have to read about chemotherapy, immunotherapy. When, like Dr. Vinita mentioned, when you cannot give chemotherapy, cisplatin, what are the other agents? Can be targeted along with radiation? So all those areas are to be, read. And all these famous trial, March meta-analysis, update, McKenzie update, and all these trials are important. Even EORTC and RTOG long-term trials that you should know. And it's actually very interesting also to read. Okay. So thank you, everyone. Thank you, Dr. Vinita and all the faculty and all the speakers, Dr. Rohan, Dr. Sukirti, Dr. Rachit. They've done a great job.
Thank you, ma'am.
Shilpi, thank you so much for taking this initiative. Very excellent meeting, lot of interaction, lot of learning. Even I learned a lot.
In fact, it was your brainchild. I really should tell this to everyone because it was conceptualized by you only, and it is really, really good initiative.
But it is nice that you're taking it forward.
Thank you, ma'am. My pleasure.
Thank you, Dr. Shilpi. Ma'am, it was an interesting class. I mean, I sat through the entire class and I really enjoyed it.
Nidhi,
Probably I
thank
learned
you so
also.
much. Nidhi, really, we forgot to thank you. Thank you so
I
much.
know, seriously, she is the backbone.
But
Thank you.
the class was very interesting.
Thank you for pushing us to do this, and of course, organizing it.
Oh, ma'am, it's always a pleasure. And it's these classes are very interesting always. We still remember our thyroid and thyroid
Yes,
classes at first class by taken by you.
excellent.
They're always very interesting. Thank you, ma'am, for
Thank
continuing this series. Thank you.
Thank you.
Okay, thank you.
Thank you.
Meet again.
Yeah, sure, definitely.
Okay, bye. Bye.